Good morning to all of you. It's another significant day for College of Physicians today. This is our second specialty update. The first one we did last month on internal medicine, and the second one is on cardiology updates. And we are collaborating with the Sri Lanka College of Cardiology. I'm very happy that the president of the College of Cardiology and the senior cardiologists in the country are here to deliver their lectures today. So first of all, I thank the president and the College of Cardiology to collaborating with us and giving their fullest support and selecting their senior members as the resource persons today. So I hope you all will get the maximum benefit of the updates that they are going to do today. I also invite Dr. Asonga Dinuvela, senior consultant cardiac electrophysiologist, to say a few words before we actually start our lectures. Over to you, Asonga.
President, College of Physicians. Thanks for collaborating with us to organize the cardiology update as a specialty day. I think we have identified some contemporary issues and topics which we have slightly changed from the standard way in order to make it more interesting. The whole idea is to provide you with the educational experience as also to give overview of what's happening in each specific area and to give you a hint of what the developments are. I think this kind of meetings are very important in a sense that now it has been the standard that the focus meetings to be conducted in a way that the education is maximal during such events. So I once again thank Dr. Ahmad Singh for organizing this, and Nino who took a lot of pain as a secretary to get things going. And I think we can start off the session, which will consist of 4 lectures, and which is roughly half an hour per lecture. I think we leave some time for discussions at the end of each lecture. Thank you. Over to you.
Thank you very much, sir, for those inspiring opening remarks. Today's sessions will be based on the form of academic presentations, where our esteemed audience is invited to engage with the speakers at the end of each session. Our first presentation is titled Clot and Clock, the dual threat of acute coronary syndrome. This academic session will be delivered by none other than Dr. Gotabe Ranasinghe, who is a well-known senior cardiologist and a general and interventional cardiologist. Dr. Gotabe Ranasinghe graduated from the Faculty of Medicine, University of Colombo, and received his advanced cardiology training at the John Radcliffe University Hospital at Oxford, UK. He has served as a consultant cardiologist in the National Institute of Cardiology and has also hosted the post of president of the Sri Lanka College of Cardiologists. Dear sir, this invitation is to you.
Thank you for kind words, and also I must thank Ceylon College of Physicians President Namal Vijayasinghe, Secretary my friend Dinuka Liyanage, and President College of Cardiology Asanka Dinuvela, and Tusita Amarasinghe. So I think I feel privileged to be here and talk about acute coronary syndrome. And so this is a very common topic, so I try my best to complete everything. But it's actually a race between clot and clock. There are two enemies here, the racing. And clot is acute occlusion of the coronary artery. Clock is how much myocardium we salvage. We should defeat the clot and let the clot win. And so early reperfusion. So that's the aim. And so this is the outline of my lecture. So introduction to acute coronary syndrome, then triage and diagnosis, then acute management and revascularization, then pharmacological treatment, complication and conclusion. So the acute coronary syndrome, I think, encompass several clinical syndromes, usually unstable angina and non-STEMI and STEMI. And so these are the main groups, three main clinical diagnoses of acute coronary syndrome, and we encounter every day. And so let's talk about bit about our local scenario, because local scenario we don't see very much in the scene. So number of AMI patients in Sri Lanka. So usually according to Sri Lanka STEMI Forum statistics as well as Ministry of Health, we have about 63,000 per year, 5,000 per month, and 175 to 200 a day. So see the staggering amount numbers. And so this one has to understand. And so the acute MI, of course, they say they don't categorize STEMI and non-STEMI, but all together here. See the number of AMI encounters Sri Lanka over the years. And from 2017 to 2023 here, 22 rather. So see again, over the years, there is an exponential rise. And so we are facing a sort of epidemic of this problem. And also, we talk about various things about this acute coronary syndrome, how the atherosclerosis begins, various theories. This is what I believe, this is the whole world now believe, inflammation. And so inflammation is the key, nothing else. And so how does inflammation start? Acute oxidative stress, oxidized LDL, endothelial dysfunction, LDL accumulation in the intima, inflammatory reaction, plaque buildup and rupture. So this is what exactly is happening with acute coronary syndrome. So the inflammation is the center, and this is the central problem for anything, everything. Not diabetes, not hypertension. Those are all risk factors, but we always traditionally talk about these things. But someone has to see what's going on there. It's an inflammation. What is this oxidative stress? All sugar and the other various oxidative stress factors, lack of sleep, all that come into play, and especially the seed oils, what we take, all matters. And so this is the trial I'm just want to highlight. It's called Cantor study, and that you can see that's proven that there is an inflammatory process happening in the endothelium. And so this is not LDL per se, it has to be oxidized LDL. So this study, of course, proved that there is an inflammation happening in the artery wall. Also rare causes of other than the inflammation, so it's Cadell syndrome, Cadell syndrome. There's another syndrome called Cornish and Cornish syndrome. So this Cadell, of course, I reported first time in the world. And so this is, of course, an autosomal dominant condition, and there is no atherosclerosis here. And so this is published recently and going as a new syndrome. You get a spontaneous coronary resection of the coronary artery, they come with acute STEMI. And so then the Cadell, of course, described some time ago, again autosomal dominant condition, and again they have more or less TIAs and neurological symptoms, but they can come later on with the STEMI. Usually young age they present. So I'm just mentioning these things. One has to understand, because we see these things in the day-to-day practice. And so Cadell and Cadell, of course, there are two variants. The mutations are different, chromosomes are different, and so therefore it's two syndromes. And so one has to remember. And Cornish syndrome, this is this described in 1991, Greek cardiologist. And so there's the allergen exposure triggers mast cell degranulation and the release of various vasoactive agents and causing atherosclerotic plaque rupture or erosion, even spasm. And you can see the various types, the coronary spasm. Of course, you see this after the bee stings and wasp stings and hornet stings. It's very common. So they say allergic reaction, because of allergic reaction they died. But if you see, sometimes it's a heart attack. And type 1, type 2, type 3. So type 1 usually vasospasm. Type 2 is where people who have already plaque, they can rupture because of this situation. And people who have got stents and also can have stent thrombosis as well as a stent restenosis because of this allergic reaction. Then the triage and the diagnosis is very important in case of acute coronary syndrome, because the clot and the clot, as I mentioned, and so you have to make sure that you have to understand that the thrombotic burden and the ischemic time matters a lot and for the clinical outcome. And so therefore the clot is very important, because early reperfusion is the most important thing to prevent myocardial damage. And so therefore initial measures for patients with present with acute coronary syndrome has to have some system: pre-hospital logistic care, time to treatment, healthcare system and system delays, emergency medical services, and even general practitioners, what they do. So their diagnosis and organization of STEMI treatment network. That's also important to minimize delay. So I'll talk about each and every one one by one. And so we introduced this wagon wheel model of STEMI care in Sri Lanka 2011, and by Sri Lanka STEMI Forum and as well as Sri Lanka Heart Association, endorsed by Ceylon College of Physicians at that time. And it's a protocol specifying the reperfusion strategy based on geographical location of patient's first medical contact and the regional availability of the cath lab services to achieve better adherence to guidelines recommendation. So we introduced this wagon wheel model, and you can see, and so the hub is actually the center, the cath lab. We can do this in our country because there are 9 provinces. All the provinces have got now cath labs. And so therefore depend on the level. So level 1 is the hub, and all the hospital we have mapped, and the primary PCI. Level 2 is outside that, and the transfer for primary PCI, and other level 3 is a pharmacoinvasive, which I'm going to talk to you later on. So this is the Western province we have already mapped. Depending on the hospitals, we can see now, so for example, Gampaha, level 3. And so it comes, you give thrombolytic therapy, transfer, pharmacoinvasive. So depending on the geographical location, we can map all 7 provinces. So that's very important. And also the quality evaluation, we have to have some idea about what's going on in Sri Lanka. These are the data. This is published in the British Medical Journal. And quality evaluation we have done in Sri Lanka, and highlight the need for improved referral pathway and stronger PCI center network. So this study concluded that AMI care quality showed moderate overall compliance with major gaps in organizational system, highlighting the need for better referral pathways and networking with PCI center system. Sri Lanka, at the moment we have gaps. So there are so we have to address this. This study beautifully showed the gaps. And also another one we published, the door to balloon time. Now see, the average is more than, this is in Western province, and this again published in BMJ, and door to balloon time more than 120 minutes, and that reflects in mortality. So this study, door to balloon time delays more than 120 minutes were associated with increase in hospital mortality with old age and female patients identified as independent predictors, highlighting the need for faster patient transfer, early decision making. There are delays in decision making, sometimes at various levels. And this is, by the way, Central Province, including National Hospital Colombo. And so diagnosis tools for suspected ACH. Of course, you see the diagnosis, the very, very important ECGs. We have to take ECG within 10 minutes. And so that's guideline very clearly mentioned here, and prevent the delay. And so ECG changes. And 2L ECG is the most important diagnostic tool. So if it is a stable angina, of course, you see normal. Unstable angina, again, you see normal. Non-STEMI, you can see T inversion. And so maybe symmetrical or asymmetrical. As STEMI, you can see beautiful FT elevation, so one should not miss that. And there are other things like AVR ST elevation. So always look at the AVR, especially when the symptoms are very suggestive of STEMI because you tend to miss this AVR. And so in case of AVR, you see beautiful, not for the patient, but for us, is ST elevation. And the other lead, you can see ST depressions. And also the new left bundle branch block and the right bundle branch block with ischemic symptom. Always we have to suspect acute coronary syndrome. That, of course, we have to look and ask for all ECG. That's people don't, I don't see that very many people do that. And other ECG changes, as I told you, see the ST, STEMI, J-point elevation. You have to differentiate from other conditions like pericarditis and all that. And then hyperacute T waves, also very suggestive of STEMI. Early stages, you can see very broad, tall T. And then D-winter T is again where the peak T, before that there's a ST depression. You can see it here. And so that's also very, very suggestive. Early stage of STEMI. And the posterior STEMI. So you can see posterior MI is suggested by the presence of ST depression in V2 to V3 and tall wave. And so you can see other leads like V7 to V8, V9, you have to take in that case and see the ST depressions and so ST elevations. So those leads. And so cerebral T waves, of course, we all know that there are cerebral conditions. So sometimes we have T inversion. That, of course, may not be an infarct. And so this is another classic ECG features of proximal LCA occlusion. You can see ST depressions and ST elevations. So it's various leads. So one has to understand these leads, the changes sometimes people miss. And so this is a kind of posterior MI, and where you see peak T in anterior-chest lead and ST elevation in opposite leads. And biomarkers, of course, high sensitivity cardiac troponin is recommended in all patients with suspected STEMI. If the clinical presentation is compatible with MI, then the rise and fall of all you can monitor. And so you have to take it above the 99th percentile. And so diagnosis is very important there with the clinical symptoms. You can see the pattern, the rising early hours, and then after 6-7 days, the levels goes down. So that's, of course, yes, but you should never wait for this test to diagnose STEMI. And so in ACC-HA2 latest guidelines, it's highlight the fact that troponin should be measured as soon as possible, preferably using high sensitivity assays. And that is a very, very important test. And also, in patients suspected of ACS with initial high sensitivity troponin, non-diagnostic, then recommend time intervals, the 1 to 2 hours later, or maybe even 3 to 6 hours later. This is the, again, latest guidelines. Then the acute management and revascularization. So emergency care, of course, initial diagnosis and monitoring once done. So acute pharmacotherapy, very important for all these acute patients. And usually we give oxygen, nitrates, pain reliefs, and some centers give beta blockers and aspirin, OP2, I12 inhibitor, depending on the situation and the condition. We always do that. And also the oxygen. Now see, if the oxygen saturation is less than 90, of course, then you have to give the oxygen. Otherwise, you should not. The guidelines strongly recommend that. And if the saturation is more than 90, and you should not do that. Now, when we were house officers, of course, we used to do each and every patient. Now you don't do, because that might cause harm. And so time, myocardial infarct size and outcome. This is the most important thing, the time to treatment and myocardial infarct size and mortality. This is a beautiful study done by Gersh and others, published in JAMA. And then time, symptom onset to reperfusion therapy. And this method, in this study, you can see every 30 minutes delay in associated with 7.5% relative risk of 1 year mortality. That's very, very significant. That this study concluded early reperfusion dramatically reduces the infarct size. Early treatment produces the greatest mortality reduction. According to this, you can see first 3 hours, significant reduction. And even late reperfusion may improve the survival. Even the myocardial salvage is small. You can see after 6 hours, the salvage is small, but still you can minimize arrhythmias, you can minimize the scar formation, you can minimize the remodeling. That is another thing happening if you even reperfuse up to even 12 hours. The selection of invasive strategy for reperfusion therapy. So this is gray score. According to that, you can select. And so in these patients, very high risk patients. So, and when the patient comes, suppose it's suspected non-STEMI, and very high risk patients, of course, immediately within 2 hours, you have to send for angiogram. And so how then you can see the very high risk features and changing dynamic ECG changes, hemodynamic instability, arrhythmias, and various things. High risk patients, again, so you can see here, the depending on gray score, that is, you can see the gray score, 8 clinical variables, and these variables together estimate the mortal risk in acute coronary syndrome. And if the gray score is more than 140, that identify the high risk STEMI, the non-STEMI patients who benefit from early the invasive therapy. They should be transferred to PCI center for revascularization. Then the low risk patients, of course, if they don't have these features, they are low risk, and you can do inpatients transfer. So you can transfer to another hospital and evaluate further and do a exercise ECG, echo, and repeat troponin, assess further, and depending on that, you decide on the revascularization. So that's for non-STEMI. The STEMI, of course, the onset of symptoms you can see depending on the mode of transport patient. Sometimes they come from on their own. Sometimes patients come through their emergency services. And so most importantly, first the medical contact. And so then from there, you decide on what type of reperfusion therapy. And so if they come within the less than expected time, that is the 2 hours, now suppose when the patient comes to you, and the ideal treatment should be the primary PCI. If you think that primary PCI can be done after 2 hours, then you should not wait and send patient for thrombolysis. All other patients, if they are coming, if you think that expected PCI can be done within 2 hours, you should do send the patient for primary PCI. There is no the question about it. That's very, very important. And so then with the type of reperfusion strategies, fibrinolysis or thrombolysis, and this therapy is important reperfusion strategy for STEMI patient. In this country still, I think more than 80% of patients get this. And so presently within 12 hours of symptoms, and so there are the primary PCI facilities not available. And successful reperfusion is generally associated with significant improvement of ischemic symptoms and ST resolution more than 50%, and very good hemodynamic status. And we know basic about this, what is happening here. Thrombin is actually activated, thrombosis, and then ultimately we use plasminogen activity to dissolve the thrombus, the fundamentals. And the clinical benefit of thrombolytic therapy is very well established. And so the significantly reduced short-term mortality in AMI, particularly in patients with STEMI or bundle branch block. And this study very clearly shows that early hours, the benefit is very much more. And the different thrombolytic agents, first generation, second generation, and third generation, you can see. And second generation, of course, we use Altiplase. Third generation, we have very fibrin-specific, very effective tenecteplase. We all know those. And first generation, by the way, streptokinase, you have to understand, you should never talk about streptokinase now. And so this is a comparison of streptokinase and Altiplase. And so this Gusto study, and see very clearly, and so the Altiplase is better than streptokinase. That's again very, very clearly evident. And so different thrombolytic agents, again comparison of streptokinase, Altiplase, tenecteplase, and Altiplase. You can see 90 minutes of patency after each therapy. The best you can see with tenecteplase and Altiplase, not streptokinase. It's about 40 to 60% patency rate. Even now they say it's lesser than that. And comparison of the altiplase and the telectroplase, of course, now this study shows the ascent to telectroplase was as effective as altiplase in reducing 30-day mortality. Now I know neurologists, they give this, they used to give altiplase, now they are giving telectroplase. Apparently there are two studies, one is equal telectroplase and altiplase, other one is actually telectroplase superior. There is now lobbying actually for telectroplase in stroke treatment. So I hope the cardiologists also doing the same thing. And the primary PCI. So primary PCI again can be defined as a reperfusion by means of coronary angioplasty or stenting for acute STEMI without prior administration of fibrillation therapy or any other antithrombotic agent. That is, remember, the primary PCI, the gold standard for STEMI treatment. And the latest ACCHA, that 2025, and ESC 2020 guidelines recommend PCI, primary PCI, the initial approach to management of STEMI. That's very clearly mentioned, this thing, because early the better. And in patient with STEMI and estimated time for first medical contact to device activation, if it is less than 120 minutes, and those patients or those patients with contraindication to fibrillation therapy transfer to PCI capable center for primary PCI. That is the recommended treatment. And this is primary PCI. You can see the first one. So you totally occluded, and then you do the opening, and then you get normal TIMI3 flow. So it is the preferred reperfusion strategy for patient STEMI if performed in a timely manner. And again, the left side, you can see the LAD totally gone, and then we open the LAD and then have the normal perfusion. So thrombolysis versus primary PCI. This is the famous meta-analysis of 23 studies. It shares the short-term clinical outcome in individual treated with primary PCI is very much better than the thrombolytic therapy. This study proved that, and primary PCI is the treatment of choice for STEMI. And then there's another strategy called pharmacoinvasive. This is actually coronary angiogram. You do with PCI of the affected artery and perform between 2 to 24 hours after successful fibrinolysis. And the timely thrombolysis and coronary angiography have a similar clinical outcome as primary PCI. Remember that you give thrombolysis therapy, nicely done, reperfuse, and then you do angiogram within 2 to the 24 hours, and so see the lesion and do the PCI. And so this is as equal as benefits sometime with primary PCI alone. And so this is the study, early Mayo trial, published in 2017. And so this study concluded in low-risk STEMI patients presenting within less than 6 hours with expected PCI delay has to be again more than 60 minutes, and then only you decide on this. And pharmacoinvasive strategy using half-dose altiplase followed by early PCI provided better myocardial reperfusion than primary PCI and represent a practical alternative where primary timely PCI is not available. So therefore you don't need to worry. And sometimes you give thrombolytic therapy and transfer the patient early and make sure that and it's nicely reperfused. So this study very clearly the benefits. And see pharmacoinvasive strategy, this particular patient gave streptokinase. Of course, when you do the angiogram, there is no opening here. Actually, it's not pharmacoinvasive, it's rescue PCI. I just want to highlight the effect of streptokinase in STEMI. And so, of course, patient we saved because of the PCI. So this is an inferior STEMI even after telectroplase, but you can see these arteries open, TIMI3 flow. And so, but we did the PCI pharmacoinvasive later on. And so indication for rescue PCI, that's where fibrinolysis fail. That means ST segment resolution less than the 50% of the original at 60 to 90 minutes of therapy. And so patient with working diagnosis STEMI who present to non-PCI center should be immediately transferred to PCI capable center for timely the treatment. So then antithrombotic therapy briefly. And so determinant of antithrombotic therapy depending on various things, of course, patient characteristics and the clinical presentation, comorbid condition and all that. And then ultimately we have to select the type of antithrombotic treatments. What we have to do is balance the ischemic risk and the bleeding risk. And so this is again antiplatelet drug, dual antiplatelet therapy, clopidogrel versus ticagrelor. So based on these results of Plato and Triton TIMID 33 trial, DAPT including aspirin and potent P2I12 inhibitor, that is either ticagrelor or prasugrel is recommended for standard treatment for STEMI patient, non-STEMI patients. So this is the study, not the clopidogrel. And then another study, ICER-REACT trial, and also demonstrated clopidogrel characterized by less potent and variable platelet inhibition. And so this study, of course, significantly reduced composite death and MI and or stroke without any increase of bleeding. So this study showed prasugrel is better than ticagrelor for STEMI patients. And so again, the selection, so PCI, non-STEMI situation, of course, you would give the aspirin or clopidogrel or prasugrel. CABG, they are going aspirin and ticagrelor or clopidogrel. And the thrombotic therapy patients, of course, if they are going for medical treatment, of course, aspirin and clopidogrel. So that is the way it is recommended now. And early aspirin discontinuation. So people who have got all these therapies and even PCI, and you don't need to, in certain situation, if the bleeding risk is high, you don't need to complete the 1 year treatment. So this is a study to show that TICO and TPAS trial that showed very clearly you can stop aspirin within 1 month and continue the ticagrelor, the balance. And so anticoagulant drug selection, again, other than the antiplatelet, you see the heparin. Heparin is given, and usually enoxaparin is preferred treatment compared to the unfractionated heparin in every situation. So that is you have to remember. And so then the complications. So we know that in acute coronary syndrome, we have all these complications, mainly the heart failure and cardiogenic shocks, left ventricular thrombus formation, ultimately they end up in strokes, the other arrhythmic condition, bradyotachyarrhythmias. And so ACC guidelines, of course, very, very clearly says stroke situation, the patient should be immediately get the patient and treat the patient with PCI and infarct-related artery. Don't attempt any other artery, only infarct-related artery. If you try to attempt other arteries, you do harm. And so a recommendation for ACS complications and various complications I have mentioned here, and especially mechanical complications. So they should be immediately angioed, and so to check for prevascularization possibility. And the bradyarrhythmias and tachyarrhythmias, again, immediately you should do the angio and treat accordingly, because you have to reperfuse. And while you are treating for this thing, the arrhythmia condition. And remember that there is another important thing in patient with, as Asanka is here, I have to mention this, in patient with post-MI, implantable cardioverter, that is ICD, implantation is recommended in selected patient with left ventricular ejection fraction is less than 40%. So at least after 40 days of post-MI. And so you have to decide, prevascularize after 40 days, still LV function is poor, I think one has to consider that. That's also important. And so then again, this low-dose rivaroxaban, liver anticoagulant agents, reduce ischemic event, but increase in bleeding risk. In patients with poor LV function, we used to, some recommended that NOAC, in addition to the dual antiplatelet therapies, some people give. But remember that ischemic complications are less, but there is a risk of bleeding there. You have to very carefully start this, the new NOAC on newer anticoagulant agent on top of a dual antiplatelet therapy because of the bleeding risk. This is a study to show that. And so follow-up patients, of course, early for the discharge, of course, first 4 weeks, you have to do a clinical review, symptom assessment, and also check for medication. Sometimes a lot of people in our studies, we have done follow-up, a lot of people don't take medication, especially dual antiplatelet therapy. And adherence is very, very important. And sometimes this time you have to do echo and to assess the LV function. And follow-up, of course, supportive healthcare choices, smoking cessation, we all learn the healthy diet, that is very important, regular exercises, healthy weight, psychological management also important, and then drugs. Antithrombotic therapy, usually dual the therapy, dual antiplatelet therapy, lipid lowering treatment, beta blockers, MRA, SGL2 now is a new thing. So make sure that they are on, especially for diabetic patient with poor LV function. I'm not going to detail on that. Then ACE inhibitors or ARBs or ARNI. ARNI is again now high on the list. So you have to start. And so then the ACHA 2025 guidelines strongly endorse, and long-term treatment, lifestyle measures, very important, that could reduce mortality in these patients. So therefore, cardiac rehabilitation is a key. So in conclusion, so ACS is driven by two the critical forces. One is coronary thrombosis and time to perfusion. That's very, very important to remember. Rapid recognition and early restoration of coronary blood flow remain the most important determinant of the survival. And the delays in presentation, system gaps, and the residual cardiovascular risk continue to impact the prognosis. So you have to address all those issues. And strengthening ACS system of care, the network, and from pre-hospital diagnosis to definitive treatment is essential to further reduce mortality. In Sri Lanka, in Western province, we have proven, and beyond any doubt, that we are lacking. We have gaps. So ACS is a race between the clot and the clock, and survival depends on who wins. Thank you. Are there questions?
Any questions you want to ask from Dr. Gotabira Singh?
Actually, I have some questions. We have over 500 Zoom participants joining online here with us. So one virtual audience person has asked that I have seen many series of young individuals with J-point elevations on inferior leads and V1, V2. But after investigation, they were not significant, maybe early repair sessions. How to differentiate those from STEMI?
Yeah, of course, very simple. And the most important for STEMI is the patient will tell you. You don't need to do anything. Patient will tell you. You have to listen to the patient. Most of the time, clinicians don't listen to the patient. And the patient will vividly describe the STEMI. And I have this thing I used to tell all the students and the PGs and the palm sign. They will tell you pain, chest pain. They will never, if they say pain here, pain there, it's called finger sign. And so that is enough. And you don't need anything. And you don't need J point, R point, May point, you don't need. And of course, there are certain situations that are important, but the most important for STEMI is clinical diagnosis. And because sometimes patient, you say, no, sir, no, nothing, you go home. Patient herself or himself doubt the doctor. They say, no, can't be, there's something wrong here. They come back and go to another doctor and see it's ST elevation here, then. So you miss the bus. So therefore, the most important is, the J point, not the ST segment, in the clinical diagnosis. Once you make a clinical diagnosis, it's STEMI. So you have to start the treatment.
And we heard a lot of questions like I'm selecting selectively. So, so if there's a post in my thrombus, what are the treatment strategies we have to start on, like triple therapy and the duration of the triple therapy, and then creating into the dual therapy?
Yeah, there are certain patients, of course, they develop thrombus. In that case, you have to do the triple therapy. And triple therapy, again, now see, starting on top of dual therapy and newer anticoagulant agents, some say, but evidence is not that strong. And still the warfarin. So you have to give warfarin. And but some all depend. Some believe that this is the latest study I showed you, 2025. They published this year, to 2026. And that shows if you add newer anticoagulant agents, sometimes there is a bleeding risk. Of course, you minimize you have a benefit, but there is a risk of bleeding. And so still the warfarin, you give warfarin. And so in that case, so you have to give, depending on the, you have to strike a balance. It's a trade-off between ischemic complication and bleeding complication. Yeah. Suppose if the patient is having high risk for bleeding complication, so might as well stop the aspirin and early, maybe 1 week, maybe 2 weeks, maybe 3 weeks. Usually 1 month you stop and continue with the other P2Y12 and the warfarin, and then reassess every month and see the thrombus and whether it's dissolving or not. Usually keep the INR between 1.5 to 2.5. usually these people improve and very well, and then you slowly stop it. And and see, monitor. You have to monitor them.
Thank you. Thank you very much.
Thank you, God. I was very interesting and excellent lecture. Thank you.
Thank you.
Thank you, sir, for that insightful and evidence-based session. Our next presentation focuses on another important cardiac condition that poses a global threat to health, and that is heart failure. The next topic is redefining heart failure management to save lives in the modern era. To present this session, I now invite over Dr. Asunga Dunuvila, consultant cardiac electrophysiologist and the current president of the Sri Lanka College of Cardiologists. Dr. Asunga Dunuvila is a pioneer in his field, having introduced ablation techniques, advanced cardiac pacing, and other rhythm device services to the Sri Lankan health field. Dear sir, the floor is yours.
Once again, let me thank Namal and Dinuka for organizing this. Now, my topic for today is heart failure, but we've given it a little bit of flavor, saying redefining heart failure in the modern era to how to save lives. So we'll be focusing on saving lives. I'll give you some information which is relevant to this, and then get along with it. Okay, heart failure it's a problem which is a contemporary and a global health problem which has enormous bearing on the health system. Because the heart failure patients are sick and they actually deteriorate slowly. The high morbidity, the hospital stay, and the burden on the healthcare is tremendous. And so it drains lots of funds from the healthcare system. And so that's one of the key messages when we talk about heart failure. Now, from an individual point of view, heart failure is a complex syndrome. There could be causes or there could be precipitants which is going to make the heart failure worse. Of course, the heart failure starts slowly, if identified early, and then progresses in such a way that then it leads to either a heart failure death or a arrhythmia-related sudden cardiac death. When you look at pathophysiology of heart failure, multiple factors are getting involved. There will be initially the cause, and then there is the neurohormonal activation, followed by ventricular remodeling, results in reduced cardiac output and increased filling pressure. So you start getting a lot of clinical syndromes, and then electrical dyssynchrony. It's not, now these kind of events do not happen in this particular order. Sometimes you may start with electrical dyssynchrony and get the rest of the things around it. So there are a lot of pathophysiological events that go on when it comes to heart failure. Now, the modern classification of heart failure has three different segments. Heart failure with preserved ejection fraction, heart failure with mild reduced ejection fraction, and heart failure with reduced ejection fraction. Now, the reduced ejection fraction is less than 40, preserved ejection fraction is more than 50%, and the in-between one is the mildly reduced one. So, the main focus and the bulk of the patients belong to heart failure with reduced ejection fraction. Now, there are lots of issues when it comes to heart failure and at different levels. So, then first, like they say, the 10 pivotal issues in the heart failure management. Some of them are related to the diagnosis, some of them are related to identification and addressing the underlying cause at different levels. And then some of them are patient management, encouraging them, make sure they get the palliative care and adherence related to all the medications. So there are a lot of issues going around heart failure, and this slide indicates how different issues are there, and then maybe within the heart failure framework and the team, these different issues can be addressed. Now, when it comes to the symptoms, NIHA class is the one which is generally addressed to. The class 1, one is in early heart failure, but there is no real functional limitation. Then write down class 4 heart failure symptoms at rest. They are short of breath at rest, very difficult to do any active work. And then also we can segment that in two different segments. ambulatory class 4 heart failure and the other more end-stage heart failure. So in between, we have mild limitations and the marked limitations depending on the exercise and functional capacity. So when it comes to diagnostic work of heart failure, if somebody is coming with acute heart failure, yes, the initial investigation should be done to exclude things like myocardial infarction or or myocarditis. And so the basic investigations like electrocardiogram, echocardiography, the chest X-rays, initial laboratory investigations, ultrasounds if are necessary to in the lung if it's a pulmonary embolism. So likewise, there is a set pattern that we initially investigate in a very quick manner to come to a diagnosis. Then beyond which, then these things like BNP and NT, pro-BNP things will differentiate between the degree of heart failure, no heart failure, and advanced heart failure. So this is our initial scheme. Now this happens while we treat for acute heart failure situations. Now beyond which, or if somebody comes with chronic heart failure, other things need to be looked into. Apart from the fact that we diagnose heart failure primarily by looking at the echoes and the other investigations, it's important to look at the underlying causes. So primarily, coronary artery disease, previous myocardial infarctions need to be kept in mind. So that's the primary cause. And then accordingly, the investigations are tailored. And the other important thing one would need to realize is the valve disease. And the valve diseases in different ways, the aortic and the mitral valve, can cause heart failure, and then we need to do the investigations along with that. The arrhythmias do play an important part. We've seen patients with ongoing tachyarrhythmias, which leading to so-called tachycardiomyopathy, and also if there are a lot of ectopics, like less than 20% over a long period of time, then you also get ectopic-related cardiomyopathy. So these also present in a similar way, but the underlying diagnosis is different. Then other different kinds of causes, ARVCs, hypertrophic cardiomyopathy, and then other things like Takotsubo's and things like that. So we need to think and tailor the investigations to come to a diagnosis. When it comes to principles of heart failure management, there are a few things one need to realize that. Now, the most important thing is guideline-directed medical therapy. Lifestyle modification is important, and this is the two initial steps that one would look into. And now, although this addresses a large segment of patients, there can be exceptions where those first two is not going to be enough. Then comes the device therapy to prevent sudden cardiac death and to improve the symptoms in certain segment of patients. The latter two, we are in advanced end-stage heart failure where we have other therapies like left ventricular assist device and cardiac transplantation are also there, but as you know, they are not yet available in this country, and this is done for the end-stage heart failure patient. Now, this reasonably recent concept of 4 pillars of heart failure and the way it should be started with the 4 different medications at the inception has provided a lot of benefits to the patients. So the initial drug, I think Dr. Gotabe has also touched this towards the latter part of his lecture, the ARNI, and that is angiotensin receptor nephrolizing inhibitors. And the rest, that is sacubitril valsartan, the traditional beta blockers in a very effective way, and again the long-standing mineralocorticoid receptor inhibitors like aldactone, spironolactone, and then reasonably new SGLT2 inhibitors. So these are the front line in heart failure management. You need, once you identify the heart failure, you initiate, and then we quickly optimize looking at the blood pressures, the renal function, and then reassess and get to the maximum doses till the patient, depending on the patient tolerability. We also should be remembering that some of the European doses may not suit the Asian races, so we need a bit of clinical sense here other than directly applying the doses. But anyway, the maximum doses are advised for them to get the maximum benefit. Now, this combination therapy has proven to reduce the cardiovascular deaths, the heart failure hospitalization, and And of course, it's important that early initiation, if you initiate it early, it improves the survival. Some flow chart, this will basically say when and how to start the treatment. The first of all is ANI, angiotensin receptor neutralizing inhibitors. Sacubitril valsartan, as you know, is available. It has become the first and the frontline treatment in heart failure. You should be starting it as early as possible. You start with a smaller dose and then titrate it up to provide the maximum benefit. If the patient is already on ACE inhibitor, you need to discontinue ACE inhibitor about 2 days before starting it. And the dose initially depends on the ACE inhibitor. If you a higher dose of ACE inhibitor, you start with a higher dose. Lower dose of ACE inhibitor, you start with a lower dose. And quickly, you need to maximize this. Now, the problem with ANI is it's quite expensive. And now I think we have about 3 or 4 products. The original one is, of course, quite pricey. The other generations are also pricey. But anyway, that's part and parcel of economy. But then it's actually needed. Now, if the ANIs is prohibitive or the economic or cost implications, then we can stick to our recognized ACE inhibitors. ACE inhibitors do provide a benefit, which has been known over a long period of time, but they don't have the nephrolizing inhibitor effect of ANI has. And so that's the segment B. So these A and B are aligned to one another. Then mineralocorticoid receptor antagonist. This has been tried and tested over a long period of time. However, the benefits of mineralocorticoid receptor antagonist was recognized more recently. So this is spironolactone and eplerenone. And so you start off with a small dose, and as low as 25 milligrams daily will have a benefit. Normally, the maximum tolerated would be about 100 milligrams daily, which you give it in divided doses. The SGLT2 inhibitors has also initially was introduced as anti-diabetic, has found to have more effect in heart failure than in diabetes. So it's a drug which addresses both purposes, and it has quite a good action, and the action it has a diuretic action as well as other beneficial action when it comes to management of heart failure, and so these should be identified and introduced early. So empagliflozin and dapagliflozin are the drugs that are in this particular group, and you need to use at least 10, although you may start off with 5, you need to use at least 10 milligrams daily. Beta blockers had been in existence for management of all cardiac conditions for so many years, over a few decades. Again, beta blockers, everybody knows, has a pivotal role in all aspects of cardiac management, and so it has also come into play in heart failure. The agents that have been proven beneficial are bisoprolol, metoprolol, and carvedilol. Depending on the patients, you can select what one needs to do. And then again, you need to start off with a smaller dose and escalate and to reach a better dose based on the heart failure level and also the heart rate. So those are the drugs that has proven benefit in the modern era of management of heart failure. Now, however, if one is overloaded, this is the acute presentation, diuretics play a very important role to decongest the lungs. So the diuretic agents, either intravenous or oral, can be tried. We have traditional furosemide, which is always available, and also torsemide. Yes, Tyto is the trade name, so that is also available as a good oral agent. Hydroxyzine and isosapide combination has been tried. I think it's not really tried here, maybe because of the availability, but in African American races, I think they are very particular that this can be added as a decongestant medication. So that is about medication. There are also other groups that can be added on, but now let's have a look at when medical therapy is not enough. And how do we diagnose that? Despite guideline-directed medical therapy in optimum doses, if the symptoms are persistent or worsening, and if the LV dysfunction is progressive, right, you then need to look at whether there is electrical dyssynchrony. Now, if there is electrical dyssynchrony, which I show you shortly, now actually that group may be the lucky group, because we can actually provide an answer to electrical dyssynchrony by using cardiac resynchronization therapy. The other group, or if their heart function is dropping to a level which is unacceptable and falls down to anything less than 40 and especially up less than 35, then the sudden cardiac death risk with arrhythmias come into play. Then you need to identify that group and then put the ICD, that's the ICD group. Now, all these devices are now called cardiac implantable electronic devices, common given name given now to from the pacemakers to CRT devices as well as the ICDs. Now, CRT in heart failure management can be divided, as I said, into two types, CIEDs. So, CRTs are for wide QRS bundle branch block patients, and then the ICDs are for the other segment. Now, what do you mean by wide QRS bundle branch block? Normally, it's a left bundle branch block, and the QRS duration is more than 150 milliseconds. But even 130 may be sufficient. In the ICD patients, they are narrow QRS. There is no dyssynchrony within their ventricle. So here we have to focus on prevention of sudden cardiac death. So let's have a look at how the flow chart happens. So this is basically now we have gone through the initial medical management, and then you divide it into left and right hand corners where the ejection fraction and the QRS duration is taken into account, and the treatment is designated based on that. And so let's have a look at a left bundle branch block. So this is classic left bundle branch block where you have the left bundle branch block pattern with the QRS width is 150 milliseconds. Now, the other changes like Q waves in V1 to V3 and with a narrow complex, they are not proper left bundle branch block. They are not going to get benefited by putting CRT. So this is the criteria you should be looking at. Proper left bundle branch block with a QRS width more than 150, even 130 would be good enough for the category. Go through the some other indications now. Now, let's have a look at what this synchrony means. Now, if you look at this initial diagram, you can, it's actually quite slow, but let's go through with it. Now, in this synchrony, now the general organized global organized coordinated contractions in the left ventricle fades. If you look at the left ventricle here, when some of the segments are contracting, other segments are moving away or they are dysfunctional. So this is called dyssynchrony. And this is normally seen, you can see the ECG when there is a left bundle branch block. You can also see it in some of the other bundle branch blocks, but it's classically the left bundle branch block that we are looking at. Now, when you want to provide resynchrony, and this biventricular pacing device has been put where we have 3 leads, where the left-sided leads goes to coronary sinus, and then the 2 standard leads which are used to for pacing. So by using all 3, now you can see the contraction is more organized. So then for the comparison, we have the first image we have desynchrony, and the second one we have good synchrony. So once the synchrony is provided, now then the heart failure starts improving, and some of them turn out to be super responsive patients where the ejection fraction become nearly normal. But even if it is a little bit more than about 10 or 15% more than the initial level, you would consider them as responders. Okay, so what does the CRT do? As we have already seen in the diagram, coordinate and improve contractile function with the ventricles. Then as a result, reduces the mortality from heart failure. And then also reduces sudden cardiac death by treating arrhythmias. And this applies to CRT defibrillators, where you have a defibrillator component here. And then if you only have a CRTP component, just by improving the left ventricular function, the risk of arrhythmias can also reduce. In responders, dramatic symptomatic improvement, and there is a good increase of quality of life, and some people even become normal. The importance of cardiac resynchronization therapy has been identified over a period of about 20-25 years by several trials. I have mention some of the trials, the initial trials. The companion and the KIHF trials were the major ones. The companion trial where CRT-P, CRT-D, this is optical medical therapy, was compared to one another. And in the KIHF, optical medical therapy and the CRT-P. So these are the ones who really took off the heart failure treatment in view of CRTs. So CRTs have been performed in and around the world since 1993. And our first CRT was performed in 2006. And gradually we have also been increasing our numbers. The world has also introduced other methods of heart failure treatment up to now. So many trials have been performed, and it has been proven without question in selected subsegments that it is going to be clearly beneficial. Now, what are the proper indications in... so if you look at the ESC guidelines, there you, as you know, that there are class 1, class 2, and class 2B indications. So the absolute indication, class 1 is left bundle branch block, ejection fraction less than 35%, QRS is more than 150, in the background of optical medical therapy being given. Now, if you put a CRT, those patients have a great chance of improving. The class 2A category, I said the other one, when the QRS duration is less than 1, or between 130 and 149. Any QRS duration less than 130 is unlikely to respond to CRT, so we should not be thinking about that. Now, another segment that can be missed out is the other bundle branch blocks. Other bundle branch blocks also can be helpful when it comes to making decisions, because sometimes you have wide QRS right bundle branch blocks or dragging QRS complexes with indefinite bundle branch block, which are more than 150 milliseconds. So those categories are found to be also responsive. There's a class 2A indication, fairly high indication. And when the lesser the width is, the recommendation is lesser. Right? But so that category is also it's an important factor when we consider CRTs. Other categories where CRTs are going to be benefited is when you have a heart block with already reduced ejection fraction. This is not primarily heart failure, but it is heart blocks over a long period of time causing LV dilatation. So therefore, in that category, rather than putting dual chamber pacing, we actually, CRTs are the better ones. Then there is this group where the atrial fibrillation dominates the whole clinical picture. When atrial fibrillation dominates the whole picture, then there are two categories that we can have it. Now, AF is there with a background indication for CRTs anyway. So that category is the first category that is onto your left-hand side. We'll need CRTs anyway. So it's like when the patient is in sinus rhythms, that is a class 2A indication. And then as a part of AF management, CRTs can be very useful when it is very uncontrolled heart rate, that you initially put a CRT, and the low ejection fraction and the mild reduced ejection fraction patients will need a CRT and AV junction ablation for better atrial fibrillation management. So those are the other indications for CRTs. So recommendations for CRT, I think we have already told. I have just briefed them out. The one category which we didn't mention is the category number 3, where CRTs will be considered as an upgrade from conventional pacemakers, where the ventricular RV pacing is excessive, and that has led to dysynchrony and heart failure. So that category, we need to upgrade them by putting a LV lead and converting them to a CRT. This is a CRT defibrillator. One of our patients, you can see that there are 3 leads there. That is one with the multipolar leads are the LV lead, which is going into coronary sinus. One with the other coil is the ICD lead, and other one is the standard pacing lead. And this is how the head looks like. ICDs are larger than pacemakers because it has a capacitor. Capacitor could be able to deliver a shock. So as a result, this is a CRT defibrillator, where you have this so-called combo device, where you put biventricular pacemaker as well as a ICD feature involved in it. This is a standard CRT without defibrillator, where the RV lead is the standard lead and the multipolar lead goes into coronary sinus. How do we resynchronize? We resynchronize in a way that atrium we program it from atrium to the left-sided lead and the left-sided lead to the right-sided lead. So mimicking the normal contraction and the normal electrical conduction on the heart. So when you mimic the normal electrical conduction of the heart, it takes you out of left bundle branch block, and its heart failure starts improving progressively to a greater benefit. So this is a post-CRT ECG. Now you can see here the left bundle branch block has disappeared. Now it gives a more rightward axis, and the L1 has become negative, meaning now the axis of electrical activation is from move closer to a normal heart, which is the difference from the initial ECG that we can obtain once a successful CRT implantation is done. Okay, so much for the CRTs. Now, who needs ICD? Now, when the heart failure is worse, when the ejection fraction falls especially below 35%, and if they have narrow QRS, then their arrhythmic risk increases. And when you compare the arrhythmic risk with the normal optimal medical therapy and the devices, it has been clearly proven in several studies, ICD shows at least 28% reduction in mortality in this particular category. So there will be no benefit for these patients from the device on the heart failure side, but there is a great benefit for them to prevent sudden cardiac death. So we have seen when you consider the ICDs, and ICDs are expensive devices, so are the CRTs, we need to also make certain decisions who's suitable and who's not from the physical point of view. If the patient is judged to be not to have a 1 year good quality life, then we don't really put ICD in. And because there's no point, patient cannot get the benefit, we just add to the cost. So that category, we would disqualify them. And ICD is also not recommended for people who are continuously in VT. We had to do something with the VT, otherwise continuous talking, they'll make their life is miserable, and also ICD battery will also deplete pretty quickly. So once those are taken off, the rest of the people you would consider for ICD implantation based on their clinical history. And of course, when we talk about a device which is really in stock, patients also have reservations. Sometimes the patients do not agree to get a device done. And we can see even after seeing patients and counseling them with regard to the need, about 20% of them would say, no, they don't want a device, they prefer medication. So in the event of patient rejection or a decline by the patient, we'll go for the next best options like medical management and so on. Some categories can be benefited by ablation, especially if it is PVC-driven polymorphic or monomorphic ventricular tachycardia, either as add-on therapy or as a primary therapy. This is how ICD looks like, and you don't have a CRT lead. The RA and the RV lead will provide a shock, and the device is, you can say, has two connections. Okay, so now we come to the question, how does one save lives in heart failure? If we take everything into account, right? And from what I said from the beginning, early diagnosis is the key. If you diagnose early and treat the heart failure and in an effective and efficient way, that itself can save lives. But we also need to remember this is really multifaceted. Now that, so a team of heart failure management should be involved in many situations. So starting guideline medical therapy as early as possible, especially the 4 pillars, and then in appropriate and adequate doses, and then add-on therapy depending on decongestion is there or not. Then treat underlying coexistence factors. If there's a coronary artery disease, aortic valve disease, atrial fibrillation, treat those, and then that will improve the survival. Then you get to the subgroup where you have the left bundle branch block and or non-left bundle branch block. There, either CRTs or ICDs will definitely prevent sudden cardiac death. Other therapies like end-stage heart failure, treatment is available, but certainly not in this country as of now. So the take-home messages is heart failure can be efficiently treated. Appropriate treatment with guideline medical therapies 4 pillars should be the key as a starting point. Do not forget to treat the underlying causes. Identify the subgroups that are needed. Please identify them. Like as electrophysiologists, we really don't want patients being referred too late when the ejection fraction is 15-20%. Even if we do a CRT, maybe it's too late. We really need to say them when they were around at least 25 to 30% and the patient is kind of ambulatory. The other things like conduction system pacing and left bundle branch pacing will take some weight of the CRT, which we didn't discuss here, but that is also in the pipeline. Thanks for listening.
Questions from Dr. Sungal.
Once again, from the virtual crowd, I have one question for you, sir. One have asked, in bradycardiomyopathies with ejection fraction less than 35 without left bundle branch, so would you recommend to go ahead with the pacemaker initially or straight away CRTP?
I think its line is you also can also have a look at the LV dimensions and to make that particular decision. And also we can also do a bradycardia study. Other investigations to find out whether it is actually sick sinus syndrome, which is leading to this. If it is sick sinus syndrome proven, I think we can straight away go for dual chamber pacing and get the heart rates higher, monitor them over a period of time to see what the response is like. But if it is a heart block and if there's LV dimensions, then LV dimensions differ and LV function is low. Then by putting dual chamber pacing, static not going to help. Then you have to go for a CRT.
And actually, we can enter into a few questions. We have a lot of questions. So one have asked the timing of starting the beta blockers after acute heart failure.
Agree. Dr. Gota will be in a better place to answer that. But then having a look at it, I think not in the initial decompensated phase. I think we need to get rid of the decompensated phase by using diuretics and the other medications. And once, or then of course also need to see whether there's bronchospasm. And then we would generally start a beta blocker soon after that. I think within a few days, we would generally like to select a selective beta blocker like bisoprolol initially and then maybe cover it all later. So both have been proven effective.
I think the more practical question would be if they are admitted while on beta blockers with acute heart failure, would you discontinue it or continue?
I think it would continue, at that time.
Thank you so much, Samvit. Excellent lecture.
Thank you very much, sir, for that excellent thought-provoking session. The third session of the day will be covering arrhythmias and atrial fibrillation management, to be precise. To deliver the academic session on the topic, when the rhythm breaks the heart, a practical approach to managing atrial fibrillation in challenging clinical scenarios, I now invite over Dr. Susitha Amarasinghe. Dr. Susitha Amarasinghe is a consultant cardiac electrophysiologist at the Institute of Cardiology at the National Hospital of Sri Lanka and currently holds the position of Joint Secretary at the College of Cardiologists. Over to you, sir.
So I thank the introduction and may I thank the President and the Secretary of the Sri Lanka College of Physicians for the kind invitation, Professor Namal Vijayasinghe and Dinukar. Thank you. And in the interest of time, I'll get on with the talk. And already you have listened to two excellent speeches from two senior prominent consultants, and I hope you will find this also as somewhat useful. And you are free to ask any questions either during or afterwards. I will, in the interest of time, I'll get going. Good afternoon, everyone again. So, AS, practical approach in challenging clinical scenarios is the topic. And as you all know, I'm sure most of you all are medical registrars, so senior registrars or people involved with managing most of the casualty or medical on-call patients. And I'm sure this is a day-to-day challenge for you all. So, so nothing new for you all. As you all encounter on a daily basis, each patient can present a different type of a challenge in managing these patients. Very often you may be the only person who need to make some critical decisions in managing, especially if they are unstable or if they are on the verge of becoming unstable. So I just summarized a few of those scenarios that comes to my mind, as well as some of the cases that I would have encountered over the last couple of months. So, for example, I'm not going to actually during this talk going to go to the basics or the basic classifications or the indications and then combination and coagulation, that type of thing. And I'm sure you all are familiar. I will try to focus on some clinical scenarios or clinical aspects of or challenges of managing these patients. So when it comes to a patient who comes to the atrial fibrillation, as you might detect on a ECG, 12-lead ECG, and if you don't get a history as such of same condition in the past, how would you deal with this type of patients? I mean, in terms of, are you going to kind of think of immediately cardioverting the patient, or are you going to think of putting them on lifelong anticoagulation, or are you going to not anticoagulate them at all, or are you going to resort to a rate control strategy only? So these are a lot of questions, each of which have sense, a lot of sense and reasons behind. So I'm just trying to get yourselves to get oriented with what you have got experience beforehand, and especially with the era of getting into the era of devices, cardiac devices, being quite common, as Gunesh already mentioned. A lot of our patients are on cardiac devices in some form or the other, maybe the bradycardia, primary bradycardia related indications, or maybe heart failure related indications. And these devices, apart from performing their task of maintaining the rhythm or preventing life-threatening arrhythmia or improving LV functions, can also function as long-term internal Holter monitoring. So for you all to understand, so they can keep a record of everything that happens. Apart from the culprit rhythm abnormality, very often these devices actually surprises us by demonstrating how often these patients go into runs of atrial fibrillation or long stretch of atrial fibrillation, which would have not been diagnosed if not for the devices. So we keep encountering these type of scenarios as well. So when it comes to such scenarios, again, a lot of diagnostic challenges or management challenges as well. So what about the pregnant patients who come with atrial fibrillation, secondary AF secondary to other conditions? I mean, very often you encounter that as well in medical casualties, like patient coming with a pneumonia, just otherwise completely normal patient coming with a pneumonia. Suddenly you realize the ECG shows atrial fibrillation. Obviously, it may be a poor prognostic factor as well, indicating the severity of pneumonia, as well as it will challenge you with managing the condition as well, apart from the primary condition. So what about the people who come for elective surgeries, have the surgery successfully, but on the day post of day one, you see they have gone into atrial fibrillation, causing a lot of challenges. Are we to anticoagulate or not immediately after the surgery? It could be non-cardiac as well as cardiac, so on and so forth. And then again, the scenario where someone who's already on anticoagulation presenting with a stroke, or presenting with a stroke while on therapeutic anticoagulation, what are you to do? And then multiple comorbidities. So these are very common scenarios. So just to sum it up, to refresh your memories, traditionally there had been classification on atrial fibrillation, but we know now there are a number of new entities apart from what we used to know, like paroxysmal persistent or permanent atrial fibrillation. I'm sure you all are familiar with the definition on this. More importantly, probably the entity of clinical atrial fibrillation versus subclinical atrial fibrillation is a more relevant kind of differential diagnosis at present. Like I mentioned earlier, people who have symptoms or people who come with a documented atrial fibrillation on a standard ECG, we consider them as clinical atrial fibrillation. By definition, if you want to keep to the real definition, generally you have to demonstrate that the run has lasted more than 30 seconds. Could be on a 12-lead ECG or could be on a single-lead ECG. That doesn't really matter as long as that has been documented. On the other hand, subclinical atrial fibrillation mostly refers to these people who is identified to have atrial fibrillation either on the clinical grade devices like what we discussed, like implantable devices, or even monitoring devices like external Holter or implantable loop recorder, or even nowadays the smart electronic devices that people use on a non-medical basis, like smartphones or watches and all that. So if these shows atrial fibrillation, most of them actually fairly accurate. I mean, medical grade ones obviously, if not even otherwise. And if the patient doesn't have any symptoms, and if it has never been recorded before, we call them subclinical atrial fibrillation. There are slight changes on managing these two entities with regards to, based on any of the guidelines, there are slight differences. So we'll try to cover that as well. And of course, the concept of AF burden, especially if a patient is under monitoring, could be monitoring in a hospital setup, or could be monitored through implanted devices or a Holter monitor. If we can quantify the total time duration the patient is in atrial fibrillation in comparison to the sinus rhythm or the total duration of the monitor time, then that is considered as AF burden, which actually is a quite significant predictor of the AF-related comorbidities, including the thromboembolic risk as well as risk of other complicating medical problems like congestive heart failure, acute coronary syndrome, and so on. Let's keep that bit. One important concept to remember about atrial fibrillation and management is that it's not just the rhythm abnormality that actually causes problems for the patient. It's actually the bigger picture of bigger pathological picture in the atria, which is called atrial cardiomyopathy. Atrial cardiomyopathy, that is a real entity where a patient may be just in and out of atrial fibrillation time. However, if you look at echo images, we might see the structural abnormalities in the atria, mostly in the left atrium, as well as probably in the right atrium. That indicates, despite the patient not being even symptomatic or not being all the time in atrial fibrillation, the structural abnormalities have set in these patients, indicating actually atrial fibrillation, not only a rhythm abnormality, it's as well quite complex structural as well as pathological abnormality. To the level that some people even suspect whether atrial fibrillation is only a trending or surrogate marker of the thromboembolic risk, and whether we are actually yet to know what is the exact underlying pathology of this quite significant thromboembolic risk as well. The time will only tell what it is exactly. So, atrial fibrillation, like acute coronary syndrome or coronary disease, is a continuous spectrum starting from pre-atrial fibrillation to the high-risk category to the pre-atrial fibrillation and the established atrial fibrillation and the permanent atrial fibrillation. So the management approaches in each of these categories are different. So as the importance of this slide is that lifestyle modification at the very early stage is the most important management step that one has to carry out to prevent very complicated future various clinical scenarios. So obviously, risk factor modification. The risk factors are quite very much in common, like as in coronary disease as well. And just one word about atrial high rate episodes. This is another term that we use for the types of different atrial arrhythmias detected through the implantable devices. And we can actually, especially if someone is having a pacemaker or a bradycardia device or tachycardia, anti-tachycardia device like ICD, these will be documented in these episodes. Even implantable loop recorder will be picking up these episodes, and some of them might indicate either actual atrial fibrillation or the future or a possibility of coexisting atrial fibrillation in these times. So we refer to them as high atrial episodes, not because the clinical significance of it may be almost the same as documented atrial fibrillation. However, not everyone can see that. And there should be some kind of a difference, because a clinician who's dealing with these type of patients may not actually see it, even if the patient is
having all the risk factors, all that risk that general patient has for a thromboembolic episode. So I'm sure all of you are familiar with the risk stratification and identifying whom to start on anticoagulation and not, as well as the use of bleeding risk cause. And the quite important message here is that none of these bleeding risk cause are to exclude the patient getting the benefit of anticoagulation. Rather, it's about designing the follow-up, whether a particular patient need a closer follow-up or whether the patient need any kind of additional reviews or tests to see whether they have any higher risk of bleeding, rather than to deny them of anticoagulation. I'll skip a couple of these slides. One message is we struggle with maintaining patients with atrial fibrillation in sinus rhythm very often. There are various interventions that we can perform to maintain sinus rhythm, including pulmonary venous isolation, as well as if there are any other substrate in these patients that leads to atrial fibrillation, like accessory pathway or atrial flutter type re-entry circuit. These things can be quite easily ablated, and in the process, you can actually cure or virtually get them free of atrial fibrillation. So, rather than struggling with some of the complex medications with a lot of side effect profile, in some patient that is quite significant, useful measure as well. And just to summarize this slide, you can see it's not just, we keep talking about the ischemic stroke as the biggest concern of these patients. However, when you look at the graph here, you can see that the combined mortality of these patients are very high, and including sudden death as well. And we do see it in our cardiac practice, that how patients actually overall deteriorate when they are in atrial fibrillation with higher burden. I will just give you a couple of brief case scenarios for you all to apply whatever the knowledge you already have, and come up with, if you want to come up with any answers, that would be very welcome. This is a patient who, this is based on a patient who we had to manage recently, 30-year-old lady, third pregnancy, presenting in the early stage of the third pregnancy, with palpitations, with documented atrial fibrillation, having some degree of LV dysfunction, mild LV dysfunction, atrial 45, with the echoes also demonstrating dilated left atrial dimensions. How are we to manage this patient? Is there anyone who can just, in a couple of slides, describe what you are going to do? Or we can see it's a very challenging scenario. Early into the pregnancy, someone coming with atrial fibrillation, are we to start on rate control medication, anticoagulation, and are you considering cardioversion? What are you going to do? What about PGs who are waiting to do the MD part for this time? Would you cardiovert this patient? Any of you consider immediate cardioversion? There's a real patient that we had to manage. Obviously, it's not uncommon, it's common. And you can see how these things get associated, like atrial fibrillation and the reduced ejection fraction and structural abnormalities. It turned out to be that the atrial fibrillation is the culprit here, though it was not known before. And the patient, we had to have quite extensive discussion with the other our colleagues in other specialties, as well as with the patient and the family about the decision on anticoagulation, cardioversion, as well as long-term rate control medication in these patients, especially during the pregnancy. So another scenario where otherwise healthy male coming with recurrent palpitations, syncope during exertion with a normal echo. I think I may have missed some sites here. Apologies about that. There were a couple of ECGs, I think, maybe in a subsequent slide. So here, essentially, this patient is someone who has had pre-excitation on the ECG. Presentation was documented atrial fibrillation, mostly causing syncope. The patient present only because of syncope palpitation. Patient has been ignoring and has been actually continuing to engage in athletic practices. So that was the easy case where we could offer him definitive management by offering ablation for excessive pathway, and he was cured of the atrial fibrillation. Another quite common challenging scenario, someone coming with atrial fibrillation while on novel oral anticoagulants, while on therapeutic novel anticoagulants, and actually with a good compliance. It's not so uncommon that they come with bad strokes. What to do? What are we going to do? It's very challenging after these scenarios, especially decision-making on acute management of stroke as well as future prevention of stroke are all challenging decisions. And then the already discussed scenario where someone coming with coexisting coronary disease, acute coronary syndrome, and impaired LV functions. You cannot ask for more than that. It's already, you have got a lot of challenges they are managing this patient. The patient coming with STEMI, with atrial fibrillation, already established LV dysfunction, still difficult, challenging situations. I'm sure some of you encountered these in the medical casualties. It's always like these type of complex cases need shared decision making. That's one concept that you need to be familiar with. There's no one simple answer for some of these patients, and it's about getting involved with other teams and identify the best scenario based on the individualized factors for each of these patients. So there were time slight changes to the way we quantify the risk as well as indication for anticoagulation. However, as a matter of fact, anyone having a stroke risk of above 2% on an annual basis, that reflecting the in men chest risk of 1 or more need anticoagulation, or in female gender 2 or more, including the female gender itself. So there had traditionally has always been a major debate about whether which is superior, rhythm or rate. The debate probably still continues. However, people have more evidence now. Rhythm control is much better. There was a time where a couple of major trials came up with the view where rhythm and rate control both equal. However, it's not the case, especially when it comes to challenging subpopulations. So about the options of rate control medications or medication that we can use in achieving the target heart rate, worldwide is actually quite limited a number of options people have, and especially because some of these medications have a quite significant side effect profile. So there are a few key concepts you need to keep in mind when you are making the decision. How bad is the atrial fibrillation related presentation or the symptoms, and whether there's any reasonable likelihood that the patient can be converted into sinus rhythm and be maintained in sinus rhythm, and what about the LV functions and the cardiac reserve, because some of these medications can be contraindicated if LV functions are reduced. So especially the calcium channel blockers, by hydropyridine calcium channel blockers, as you know, should not be used when the ejection fraction is less than 40, because it can further suppress the LV functions. What would be the approach one has to follow if when someone comes with very rapid heart rates, especially in the medical casualties in the middle of the night? This is something that you encounter, and it's always tempting to go for immediate cardioversion. Obviously, if there are very clear indications if a patient is hemodynamically unstable or has worsening heart failure, acute left ventricular failure, is a quite clear indication for cardioversion. Obviously, taking some degree of risk on the side of thromboembolic complications as the procedure as a life-saving measure. On the other hand, if it is not the case, if the patient is not hemodynamically unstable and not in decompensated heart failure, obviously you can consider based on basic principles of managing managing this the high ventricular rates, either to aim at ventricular rate control. And one thing you need to understand is we are not actually trying to control the atrial fibrillation rate. It's actually the response of the ventricles to the atrial fibrillation, that, or the conduction to the AV node, that we are mostly controlling in this situation. So, if someone is having established heart failure, the threshold to go for a cardioversion after proper anticoagulation is quite high, as this can improve the prognosis of survival in heart failure if a patient can be maintained in sinus rhythm afterwards. On the other hand, rate control alone, if the stable LV punctures and structurally abnormal heart or dilated chambers, even if he cardiover, it's unlikely that the patient is going to remain in sinus rhythm. Therefore, taking all the trouble to put them, to consider them for cardioversion may not be the ideal in that situation. So that's the summary on those slides. And like we discussed, pregnancy, cardioversion is not contraindicated. There's a common misconception. Cardioversion can be either dangerous for the mother or the child. Not really. It's probably one of the safest options, done in the right way. And probably some of the medication that we have to use, if they are not going for electrical cardioversion, might be more damaging the fetus and the mother than the electrical cardioversion. What I was referring to actually is the electrical cardioversion. On the other hand, if someone is going to remain in atrial fibrillation with any other additional risk factors on increase in the thromboembolic risk, then of course we are left with a very challenging clinical scenario where we have to select one of the few options of anticoagulation, none of which are generally like without harm. So obviously we have to take some risk on that and identify the best options available on the given scenario, including the patient's wishes as well. A few key concepts on managing a secondary AF or the AF when it is associated with quite critical other medical condition or surgical condition. Like we discussed, any type of infection or sepsis associated atrial fibrillation is quite common. Most of the time, actually, that may have been triggered due to the infection, and long-term decision making in the setup is not very advisable. However, some degree of follow-up is the generally advised measure based on the guidelines. So basically, what it means is, if there's acute episode of AF during an infection or a critical illness, you might have to give them plan them for anticoagulation for a set limit like 3 months or so, and review, and this have a target to terminate the decision on anticoagulation afterwards if there's no any evidence of ongoing risk of recurrence of atrial fibrillation. So the same is for the motor control as well. The other challenging situation comes in these categories of patients who do not come under the traditional risk factors of atrial fibrillation that is reflected in the chest score, but on a daily basis we keep seeing actually are predisposed to atrial fibrillation, like chronic pulmonary diseases, obesity, extreme physical exertion, and so on. And the management again based on individual basis. If the rhythm control is it's going to have some distinct advantage. Obviously, that chance should be given to the patient and with a careful discussion. Hyperthyroidism is a common scenario. Obviously, these patients are likely to become euthyroid in time to come, and very often when they come out of it, the hyperthyroid state, and given some reasonable time for recovery, even the structural abnormalities that one might see in the heart might improve, and the atrial fibrillation also, there's a reasonably good likelihood they might come out of atrial fibrillation also in the long term. So therefore, these are the patients that you have to have a plan on reviewing and then revising the decision making. As I mentioned earlier, there are some fortunate categories of patients who have some kind of underlying condition that can be corrected clearly, and therefore this type of a quite messy lifelong problem can be completely taken out of their medical profile. In the interest of time, I think I'll have to skip some of these slides. Apart from medication, like we discussed, the options we would offer very complex patients are either radiofrequency ablation of the atrial fibrillation substrate, which is in the left atrium and in the pulmonary veins, or if you feel it's not going very successful due to associated significant structural abnormalities, in some selected category of patients, actually, after offering them to go for a device, there's a very good case for a AV nodal ablation, where we get rid of the conduction into the ventricle, the fast atrial runs getting into the ventricle, and it's well proven that that category of patients do very well subsequently, especially if they have failed on multiple antiarrhythmic and rate control medication. So remember about the place of AV nodal ablation in desperate situations. As you all know, antiarrhythmics are very tricky. They can be pro-arrhythmic very often, and none of them are without any side effects. So it's a very challenging situation. There are a few basic things that you have to monitor all the time under surveillance, keep under surveillance in these patients. So our time is up, and I'm happy to share some of these slides for you, for the PGs, so you don't worry about taking this thing. And discontinuing oral anticoagulants, when you are encountering a patient who was either needing to have unplanned urgent surgery or elective surgery, there are various protocols. When it comes to cardiac procedures, especially cardiac-related procedures, we tend not to stop them, because most of these cardiac procedures will anyway carry risk of thromboembolic events if the patient is not on adequate anticoagulation. Apart from the cardiac procedures, non-cardiac surgeries, you have to categorize them, you have to put them under to quantify the risk of bleeding based on the surgery. If it is low bleeding risk, 1 day prior to withholding them is good enough. If a high-risk surgery, based on the agent we are talking about, is either 2 to 4 days, if it's a NOAC. If it is warfarin, actually, again, if it's a minor surgery, the time range would be 1 to 3 days, up to 5 days if it's a major surgery, and restarting as well the same way. So this bridging concept, putting them, withholding the anticoagulant, regular anticoagulant, and putting them on heparin, form of heparin, low molecular weight heparin, or otherwise, is not widely used anymore, because it has proven that it causes a lot of issues with bleeding. And always it's challenging when we are encountering patients who have quite advanced liver disease or kidney disease as well as malignancies, and very often if it's significant enough, then decision making is going to be individual based. So quite extensive area to summarize in within 20 to 25 minutes. I'm happy to answer if there are any questions. I'm sure my colleagues as well.
Any questions from Vitam Singh?
Susita. Yeah, thank you. Excellent lecture. And so actually, as you said, the AF is so common, and I'm just getting a message from Coronary Hospital. One of the junior SHO, Sanjay, is just sending random. He didn't know that you are lecturing on this thing.
All right.
Yeah, this is not from the work. This is a question. Foreigner, Swedish, she's 70 years old, being treated for community-acquired pneumonia with very high CRP, was stable and improving, but all of a sudden got tachycardia, past history of diabetes, hypertension, hypertension, mild PhD. And he sent me the ECG. Of course, I don't need to show it, but it's definitely. And how do you manage?
Exactly what is, I mean, this is one of those challenging cases, obviously, the infection of sepsis.
Yeah.
That's the primary thing there.
Yeah, pneumonia.
Pneumonia, yeah. So it's about managing the acute situation, overall managing the patient. some degree of tachycardia is going to be there in a patient with sepsis like that or pneumonia like that. So we have to also understand that aspect where we are not aiming for a very strict rate control in a patient like that. More importantly, at least during the acute phase, the patient will need therapeutic anticoagulation. But I think this the presence of atrial fibrillation in this patient is a bad prognosis. In fact, I am just Dr. Anna and other physicians will probably know more than us about indicating bad prognosis of the pneumonia itself.
So, can we go to the case number 1? I think Pages might want to answer with that.
Pregnancy.
Ejection fraction 45.
Yes.
And
the pregnant lady. So that was a pregnant lady who came in her third pregnancy in the early stage, 10 weeks of POA. And like symptoms of palpitation, the ECG is found to have atrial fibrillation with mild, ejection fraction around 45 with some degree of dilatation in the chambers. And patient in persistent atrial fibrillation on that occasion. So the questions, basically I want them to think, are they going to consider cardioversion? In that case, when? And what are the preparations likewise? Anybody want to discuss that case? If you have time. If not, basically this type of patient need, what we did as well, was to establish them on anticoagulation. The options are low molecular weight heparin or warfarin. Initial 12 weeks, they prepare low molecular weight heparin. This discussion has been always going on. But if the warfarin dose is not very high, up to 5 milligrams or so, once the patient is in a situation where we can discharge, can be kept on that degree of warfarin if we can achieve the target INR. And the main reason why we decided on anticoagulating the patient was because we felt that offering cardioversion, patient going to have multiple benefits, including there's a very good scope for improving LV functions, which was the case actually. Towards the end of the pregnancy, the patient, we had to cardiovert the patient halfway, and towards the term, patient's LV functions were also found to be better, and patient came out of the anticoagulation by that time. So it looks like
good. I think medical management initially might also work with bisoprolol and digoxin. Both are safe in pregnancy. Digoxin can actually convert.
Yeah, till cardioversion, we were keeping them to patient on bisoprolol, and you would say even digoxin will be very useful. Yeah, sure.
Right, and test the over long period of time.
Sure.
Certainly not amiodarone. No, we can't give it that good.
Unless, exactly. But that's why the electrical cardioversion has a better place than amiodarone in that setting. Amiodarone also we aiming for cardioversion, but we use in that place.
One thing one needs to remember is sometimes without chemical assistance, the cardioversions don't work.
Yes.
Yeah. So then
yes, we have to prime with the antiarrhythmic as well. Yeah, but not in that particular patient. The bisoprolol and digoxin combination is a really good one. Yeah. One word about digoxin actually. Digoxin was very commonly used some time ago, and then it went out of favor because people thought it's proarrhythmic, it can cause a lot of problems, digoxin toxicity and all that. Now again, it's openly admitted that digoxin is a very useful drug, especially in these patients with combination of LV dysfunction and atrial fibrillation or tachyarrhythmias, atrial arrhythmias, not ventricular arrhythmia. It's not a bad drug. Undermonitored. Thank you for highlighting that.
Thank you. Excellent presentation.
Thank you, sir, for that informative and clinically relevant lecture. We now move on to the final academic session for the day, and it is based on pulmonary hypertension as a complex condition requiring careful diagnostic evaluation and multidisciplinary management. To bring you the topic of a clinical approach to pulmonary hypertension, I would like to now welcome Dr. Bhathiya Ranasinghe, who is a general and interventional cardiologist from the National Institute of Cardiology at National Hospital of Sri Lanka.
Thank you. I think we learned for 3 important key areas. Good afternoon, everybody. And thank you very much for the College of Physicians, the President and the Secretary inviting us to host this session. And I would like to also to add Dr. Anandaraj, who is still listening. And in fact, I was a student of him when we had our MD class. That was when I did my MD in profanity in 2009. He's still there. Nice to see you, sir. Right. And can I get my slides? Right. So without further delay, this is an important topic. The fact that this is one of the most neglected and ill-treated areas in cardiology and also medicine, pulmonary hypertension. The thing is, most of the patients are diagnosed late. If I are to tell you two clinical scenarios, when I was a senior registrar, immediately after Part 2 exam, one of the anesthetic doctors came with the syncope. I'm sure Dr. Gotaban Singh can remember, he was the RC type. And I'm sure the Dr. Dunilo also, and Sushita also. Syncope and colon down on exercise stage. And she was not done echocardiogram because the reason for doing exercise was exertional angina. And then later found to have severe pulmonary hypertension. With the guideline medical therapy, she lived for 10 years. She ended up in a heart-lung transplant. Unfortunately, she died of the infection. And the second clinical scenario was a patient that another consultant, a pediatrician, whom I was able to manage all throughout, came very late, effort dyspnea, which was neglected for 3 years. Effort dyspnea. We, as doctors, we tend to neglect. So what about the public? Now, she's a consultant too, right? And she had several episodes of pulmonary hypertensive crisis with low saturation, low cardiac output, was on ambulatory oxygen therapy. We asked her to get lung transplants, but it didn't work out. And finally, again came with a pulmonary hypertensive, bad crisis, recurrent crisis, she died. So both were consultants diagnosed late. Right. So that means, what about the public? So we are missing this disease. Because people present with effort dyspnea, sometimes effort angina or syncope, and you miss it. Let me talk with that interest, the definition of pulmonary hypertension. Where the WHO defined pulmonary hypertension, where the mean pulmonary artery blood pressure is more than 20, measured by right heart catheterization, and they have the pulmonary resistance more than 2 units. It doesn't look great, right? We can calculate and give it to you by doing right heart cardiac catheterization. But of course, if the pulmonary capillary wedge pressure is less than 15, you say group 1 pulmonary hypertension. That is where the primary pulmonary hypertension or pulmonary arterial hypertension. So WHO classified the pulmonary hypertension into 5 main categories, where the number 1 is pulmonary arterial hypertension. There are many causes for that. That's a disease in the pulmonary artery. The secondly, pulmonary hypertension to left heart disease, which I'm going to come one by one, like due to maybe mitral stenosis, maybe a heart failure, maybe aortic stenosis, mitral regurgitation. The backward pressure gets transmitted and you get pulmonary hypertension. The group 3 pulmonary hypertension is hypoxic conditions and the lung disease. And then the 4th is chronic thromboembolic pulmonary hypertension due to thromboembolism. And the group 5 is miscellaneous causes. Now, there are various causes for the categories that I have mentioned. But why this classification is important? Because the treatment differs. You can't put the drugs that are beneficial for group 1 to other categories because it's not going to be beneficial. That is why the differentiation is utmost important. The moment somebody label pulmonary hypertension, we have seen everybody started sildenafil, bosantan, which is not the case. Everybody does not benefit. So categorization and identify the cause for pulmonary hypertension is utmost important. So if you look at group 1 hypertension, that is the category where most of our drugs are going to be beneficial. Idiopathic, hereditary drugs, various causes, connective disorders, right, all that. And then the group 2, due to heart failure, where then of course maybe valvular heart disease, cardiomyopathies, those patients you have to treat the heart disease, not the pulmonary hypertension. And then once you correct the left heart disease, so automatically the pulmonary hypertension get corrected. And then pulmonary hypertension due to lung disease, of course, you have to treat the lung disease. If it is a hypoxia, you have to treat with oxygen. If there's a COPD or asthma, then you have to treat with bronchodilators, but not the drugs that may benefiting in class 1. And then the fourth category is pulmonary embolism. There, of course, in the acute phase, the management is different, thrombolysis and then thrombus aspiration, but the chronic phase, still there's a place for treatment surgically as well as medically. And then the category 5, of course, depending on the cause, treatment differs. So, having understood the categorization of pulmonary hypertension, it is at most important to identify what is pathophysiology, because the medications targeted depend on the pathophysiology. So, firstly, you get pulmonary vasoconstriction. Then, of course, you get vascular remodeling and smooth muscle proliferation. So, pulmonary artery become hypertrophic because smooth muscles enlarge. So, hypertrophic. And then the pulmonary vasoconstriction, that is due to endothelial dysfunction in the pulmonary artery. Because your targeted therapy different depending on where the pathology is. And then, as you say, endothelial dysfunction, right? Because if the endothelial level goes up, pulmonary vasculature constricts. If the nitric oxide comes down, it constricts. That's why our treatment depends on, that's why we give inhaled nitric oxide. That's why we give prostacyclin. That's why we give endothelin blockers like bosantan. So that's why you have to understand the importance of pathophysiology here. And then increase pulmonary vascular resistance. When the pulmonary vascular resistance increases, of course, the pumping chamber becomes hypertrophic. That is right ventricle. And to the degree that if it continue to have the same pressure, right ventricular fails, and then you get pericardial effusion, then goes to terminal stage of pulmonary hypertension. There's the same mechanism where you get the endothelial dysfunction, hypertrophy of the muscles, and then the right ventricular hypertrophy, finally right ventricular fails, and pericardial effusion, and they end up in death. And meanwhile, any of these pulmonary hypertensive patients, especially the group 1, at times can go into pulmonary hypertensive crisis. So, moment they go into pulmonary hypertensive crisis, if you don't manage them properly, they end up in a death. Right? So, very important to understand the pulmonary hypertensive crisis, which I'm going to talk in my other slides as well. So, clinical features, as I can question, progressive exertional dyspnea. This is one of the causes for exertional dyspnea. As I correctly said, one of the consultants which was diagnosed late, exertional dyspnea. She attributed that it's normal. And then fatigue and reduced exercise capacity. Some people get chest pain. Why? Because of the right ventricular hypertrophy. They can get chest pain. And also syncope. One of the commonest causes of syncope, they get exertional syncope. When they exert, because you can't have the preload on the left ventricle because with the exercise, and they faint, syncope, as a compensatory mechanism. They fall down to have the good preload on the left ventricle and good output. And signs, of course, loud P2, right ventricular heave, tricuspid regurgitation, murmur, edema. If there are medical registrars and it shows even, you can feel your second heart sound. The degree when the patient is pulmonary hypertension is severe. You can feel it and auscultate, you will hear the loud P2. Don't miss this. And then, with the same clinical, in the interest of time, I go. And what is this? This is worse than the CKD. This is worse than the stage renal disease. This is worse than any other illness. I think a moment I diagnose pulmonary hypertension patient, my options are, limited. But now, of course, with the advance of medicine, the transplant, organ transplant, new medication, it has got some good hope. But if you're untreated, their survival is 2.8 years without treatment. But now treatment, it can be 5 years survival can be increased to 70%. But you have to correctly identify the cause, treat according to the cause. Death usually occurs due to right ventricular failure, as I mentioned. So what are the prognostic indicators? A patient comes to you, sometimes patient can ask you, how much life do I have? Nowadays, patients are not foolish. They have smartphones. Moment you declare you have pulmonary hypertension, you can Google and find out what my prognosis is, what the disease that I have. Don't lie them. Tell the truth. What you can offer. What are the future treatment strategies you can offer? So WHO functional class. If they are unable to walk, which I'm going to cover in few slides with the 6-minute walk test, and then they are poor prognosis. Hemodynamic parameters, right? Low cardiac output, high myocardial right ventricular function, which is an important thing. Like we calculate with TAPSIN, the RV function is poor. They have to have poor prognosis. And the BNP, if it's higher the BNP, poor the prognosis in pulmonary hypertension. So diagnosis. ECG. What do you have in ECG? The tool R waving V1, right ventricular hypertrophy, and right ventricular strain pattern. Don't miss this. Chest X-ray, prominent pulmonary arteries, and then right ventricular enlargement. When the right ventricular enlargement, the LV apex shifts off. These are findings of a chest X-ray. Of course, the severe the pulmonary hypertension, you can have oligemia of the lung fields as well. And the echo, dilated right side, pulmonary artery, right atrium, right ventricular hypertrophy, dilated IVC, and RV failure. So, if you look here, this is a patient who had pulmonary hypertension. You can see due to left heart disease. You can see mitral stenosis. You can see the LA is dilated, and the intra-atrial septum is bulging to the right side because of raised intra-atrial pressure. And then you can see severe pulmonary hypertension and TRPG of 70. So this patient was offered PTMC, and then immediately pressure dropped. Immediately pressure dropped, pulmonary artery pressure. And she could run after that. That is the category to pulmonary hypertension. Now, one of the things that we don't do as cardiologists in Sri Lanka is the right heart cardiac catheterization because the work called, but we sometimes personally do it. I sometimes personally do this because it's a very important. These where you diagnose the exact cause for the pulmonary hypertension. Where confirm the diagnosis of pulmonary hypertension, you know how much decrease the pulmonary pressure you have it by putting a swan gas catheter. You can differentiate whether it's pre-capillary or post-capillary. Because if the wedge pressure is less than 15, it's going to be group 1 pulmonary hypertension. All the rest is more than 15. All the rest is less than 15. Right? And so more than 15, sorry. Assess severity and hemodynamics, perform vasoreactive testing. During right heart cardiac catheterization, we do vasoreactive testing. Because you know certain percentage benefit from calcium channel blockers. Only certain percentage. About 10 to 15%. That's all. And that group is recognized by doing right heart cardiac catheterization. Because the pulmonary artery pressure drops when you give the nitric oxide inhalation. That's the group that's going to benefit. Or inhale iloprost. It has to be dropped more than 10 millimeters mercury. Don't just haphazardly adding medication add to side effects and without no reason. And guide treatment decisions, evaluate response to therapy. All can be done right. It's a simple procedure. Either you can go interjugular or right, and you put a Swan's gas catheter, and you can do all your challenging tests. You can get the wedge pressure here, and then come to a correct diagnosis. This is what the wedge pressure is all about, right? So if the wedge pressure, if NA pressure is high, or pulmonary venous pressure is high, then the wedge pressure is high due to left heart disease, right? But if it is group 1, then the pulmonary capillary wedge pressure is less than 15. And remember, sometimes some patients have pulmonary venous stenosis as well. That is also one of the causes for pulmonary hypertension. So, how you do it? In the cath lab, you give nitric oxide or iloprost inhaler and then measure the pulmonary artery pressure. And that group will benefit from calcium channel blockers. So pulmonary arterial hypertension, which I already told, and the causes are I have already mentioned. With the interest of time, I'm not going to mention all that. So there can be idiopathy, drug-induced, connective tissue disorders, HIV infection, all that. And then the pulmonary hypertension secondary left heart disease, the mitral stenosis or MR or AR can lead to raised left atrial pressure, and then it will back onto the pulmonary artery and then can cause it. So the treatment is correct the left heart disease. If there's a heart failure, treat the heart failure. If there's a valvular problem, correct the valvular problem. Pulmonary hypertension lung disease, it can be interstitial lung disease, it can be COPD. Then you get, if you don't treat them correctly, then they get pulmonary hypertension, which is called copulmonale. And then, of course, treatment is not the drugs that you are giving to group 1, treat the host. And these patients, especially the treatment also different. Suppose if the patient has severe pulmonary hypertension, has come to irreversible stage, these patients, if the right ventricular function is normal, you only do a lung transplant, not the heart lung. Okay? But that is also very important, right? Because the moment you transplant the lung, the heart is okay, right? So this is what's going to happen in lung disease, as I mentioned. So pulmonary hypertension, thromboembolic pulmonary hypertension. So there, in people, if you don't treat, you can see the endothelium proliferates. There's a plexiform lesions going to happen, right? So initially, if you don't treat, these are another thing that we miss at the pulmonary embolism stage. Most of the patients are either go to mortuary, or especially surgeons do a fantastic surgery, maybe hip surgery or pelvic surgery or whatever, and then end up in the pulmonary embolism and they die. And even if you are lucky enough pulmonary embolism, you detect, because they are not in the main pulmonary artery. If you have a thrombus in the main pulmonary artery, they don't come to hospital. But if they have in the subpulmonic level, they come to hospital. But these are diagnosed people most often missed. So, little bit about 6-minute walk test. So, everybody must know how to do a 6-minute walk test. It's true for pulmonary hypertension as well. It measures the exercise capacity, it measures the disease severity, it measures the prognosis, it's important response to therapy. I never start pulmonary hypertension medication without doing a 6-minute walk test. Otherwise, I don't know if it's going to benefit or not. How much distance, that their traveling distance has to improve, their saturation has to improve, and their symptoms has to be improved. If the medications are going to be benefited, I'm sure my registrars will agree. So every time we do that as the 6-minute walk test before starting therapy. So measurements recorded, distance walk, heart rate, the blood pressure, oxygen dyspnea score. So after 6 months, 3 months, then you can repeat and see what distance they can travel further. So risk stratification, the other thing that you have to do, you have to risk stratify the pulmonary hypertension with a low risk, intermediate risk, high risk. So if they have more symptoms, they will be more high risk. If they can walk less, they will be high risk. If they have syncope, several syncopal episodes, they are high risk. So in the interest of time, I'm going to now management. When it comes to management of pulmonary hypertension, there are general measures and definitive therapy. What are the general measures? Don't forget, it's just medications. Treat the underlying cause, as I correctly mentioned. Diuretics and oxygen therapy. Don't overload diuretics because they are preload dependent. Only remove the fluid that is moved. If you have ankle edema, give a diuretic small dose to remove the edema. Don't load them. Otherwise, if you dry them, they are going to be more symptomatic. Don't do that. Don't do that mistake. Anticoagulation in selected patients. Specific therapy, endothelin receptor antagonists, and the prostacyclin, all these beneficial drugs. And general measures. So, of course, physical activity and rehabilitation is very important. Oxygen therapy, because oxygen is harmful. If your oxygen saturation is good, don't give oxygen. It's harmful. But if the oxygen saturation is less than 90%, then you have to give. Correct anemia. Because very important. Because they are symptomatic. Sometimes hemoglobin is 6. Correct it. diuretics to the degree to, correct the volume. Anticoagulation, if there's a thromboembolic or if there's severe RV failure. Vaccination, don't forget, moment they get the infection, that's where they go worse. Make sure they are vaccinated against pneumococci and the influenza. Don't forget about it. And then avoid pregnancy. Please, moment you detect, counsel not to become pregnant. Have to discuss the contraceptive methods. If you go to maternal morbidity and mortality meeting, this is one of the commonest causes of death, maternal death. Psychological support, referral to a specialized pulmonary hypertension centers if you don't know how to manage it. So, other thing is, other than the general measures, you have to make sure you optimize the right ventricle. Exclude ischemia. If there's a right coronary artery occlusion, then the right ventricle won't get perfused. The right ventricle become failed. If there's a block, correct it. And if there's a RV dysfunction due to fluid overload, correct the fluid overload. So definitive therapy are these. These are the calcium channel blockers, but that benefit only the trial-proven group. And then endothelin receptor antagonists and the phosphodiesterase inhibitors, which I'm not going to highlight the drugs. Anybody can read about the drugs. Moment you diagnose, moment you risk stratify, moment you know which group benefits. So, what are the advanced end-stage therapy? So, you can do combination pulmonary hypertension therapy, control IV prostacyclin, balloon atrial septostomy, lung transplant, heart-lung transplant. These are the advanced therapies we do. Sometimes we put ECMO also. If we have a transplant, we can put ECMO as a supportive or a bridging therapy until we get the transplant organized. So pregnancy and pulmonary hypertension, please make sure, avoid. If you detect it, contraception, IUD, AI, IUD, progesterone only contraception, don't give estrogen because they can give thrombosis, right? And then if pregnancy occurs, then you have to discuss if you need termination, terminate. Intensive monitoring is utmost essential. So one word about pulmonary hypertensive crisis. It's a life-threatening rise in pulmonary vascular resistance, leading to sudden increase in pulmonary artery pressure, RV failure, reduced left ventricular filling, and severe hypotension and shock. So how do you manage? Give high-flow oxygen if you're in crisis. Avoid triggers like hypoxia, hypercapnia, acidosis, pain, agitation. Reduce pulmonary vascular resistance by giving inhaled nitric oxide, which sometimes only inhaled nitric oxide we have in this country is either with the surgeons, cardiothoracic, or else the pediatric intensives. Even for the last patient who was in pulmonary hypertension, we could not find the nitric oxide cylinder. That's the only treatment. And then milrinone, which will support the right ventricle, reduces the pulmonary artery pressure, increase the right ventricular outflow. Maintain systolic blood pressure. Why it is important to maintain the systolic blood pressure? Why? Because if the systemic blood pressure is low, coronary perfusion become low. If the coronary perfusion become low, right ventricle become more failure. Therefore, you add noradrenaline, vasopressors, to increase the systemic pressure a bit, while adding the pulmonary hypertensive medications. Optimize fluid status and rescue therapy. Of course, in advanced centers, you can order ECMO and mechanical support and urgent lung or heart-lung transplant. So, having said that, I will tell you, this is a case presentation of a 20-year-old female presenting with severe dyspnea. Actually, this patient came for the channeling, waiting for a marriage. On examination, lungs was clear. So, you can see S1, Q3, T3 pattern, RVH pattern. So, this patient had presented with effort dyspnea while distributing the wedding cards for the wedding. And she felt, everybody thought asthma and given inhalers. This is a common thing. Even pregnancy, sometimes people give inhalers. Even for mitral stenosis, people give inhalers. Even cardiomyopathy. So what is these X-ray shows? Any register have to have a gap. Can you see acute cutoffs of the left pulmonary artery? That's oligemia on the left side. And you can see vasculature on the right side. That's a sign of pulmonary embolism. And then this echocardiogram, you can see D-shaped septum. And of course, right ventricular mid-wall hypokinesia. That causes Macken's sign. And this patient, you can see large pulmonary emboli, both arteries. She was so symptomatic. And we took, I'm sure Dr. Gota Balancing can remember, sir, that this patient, right? So we took because this patient was not responding to anything. After 2 weeks, all thrombi. So we took him to cath lab. And you can see a thrombus here. And then we did the crushing of the thrombus with a balloon. You can see that's the balloon inflated. And then it became better. And then you can see lung became very arborized on the left side. And then the chest X-ray after, you can see lung has become now more vascular, Christ. And then this is the echo afterwards. Now see, RV is nicely working. No pulmonary hypertension. Now the CTP was cleared after the event. And then patient had a nice marriage. And then, thank you very much. And then just the final slide. Okay, take home message. So group 1, pulmonary hypertension, targeted pulmonary vasodilator therapy. Group 2 and 3 treat underlying heart and lung disease. Group A, pulmonary endarterectomy can be done if you correctly identify. So advanced disease needs transplantation. So what is important message is make the correct diagnosis, identify the cause, treat for the cause, and then you will have a nice patient in front of you. This is a disease that everybody must know, not to miss. Thank you very much.
Any questions from Dr. Bhati Ransinga? Any questions?
Actually, we have a lot of questions there, but in the interest of the time, so can get one question from the virtual audience. Like the one asked, like, would you recommend doing reversibility testing on oxygen alone?
Sorry?
Reversibility testing on oxygen alone, while since we don't have inhaled nitric oxide.
It doesn't make a difference. Because even if you go oxygen therapy or not, if there's a beneficial, if there's a reversible component, what we look in reversible testing is the drop in pulmonary artery pressure by 10 millimeters mercury. If you give nitric oxide, it has to drop by 10 millimeters mercury without affecting the cardiac output. That we can measure by doing a right heart cardiac catheterization very easily. Either you can give inhale nitric oxide or you can give the ileoprost inhaler. And that if you prove that, those are the ones going to benefit from the calcium channel blockers.
Dear sir, thank you for that rational and comprehensive academic session. Now, to offer our academic resource personnel a token of appreciation, I would like to invite over the President of the Ceylon College of Physicians, Professor Namal Vijayasinghe, to the stage. In order of contribution, I would like to also invite over to the stage, first for his informative lecture on acute coronary syndrome diagnosis and management, Dr. Gotabe Ranasinghe, to receive his token of appreciation. Next, for his enlightening lecture on redefining heart failure management to save lives in the modern era, I would like to invite over Dr. Asuka Duvela. Thirdly, for his timeless lecture on atrial fibrillation management, I would like to invite over Dr. Susita Ambasinghe. Finally, for the lecture on pulmonary hypertension, a clinical approach, to Dr. Bhati Ranasinghe. Dear ladies and gentlemen, with that, we have now come to the conclusion of today's CCP specialty update on cardiology. On behalf of the Ceylon College of Physicians, I would like to thank all the organizers, academics, resource personnel, and also to the excellent audience that was present with us today. We wish you a successful and a pleasant day ahead. Thank you.